Quiero presentar al doctor Knomo, Vuyisile, que es el jefe de valvulopatías de la Clínica Mayo. Es un amigo cercano nuestro, ha estado presencial muchas veces acá con nosotros. Hoy nos va a dar la charla desde allá, desde la Clínica Mayo. Así que bienvenido, Vuy. Después queremos escuchar tus opiniones con respecto a las charlas también y tu discusión. Y él nos va a hablar sobre cómo diagnosticar y cuándo tratar la válvula tricúspide, que es la gran dificultad que tenemos hoy en día y que va en crecimiento. Así que, Vuy, hi.
You're there.
Hi, Flo. Thank you very much for having me at the conference. Hi, Martin, and greetings to all the panelists. Can you guys hear me?
Yes, perfect.
Great. We can hear you, yes.
So I need to share my screen with you here.
Sí, sí. Yes. Dice que lo pongan en pantalla. Ahí está. Que comparta. Ahí está. There we are.
Can you see that?
No, pero
Yes, yes, yes.
lo vemos.
No, yes, yes.
Okay, should I go ahead?
Go ahead.
Yes, go ahead. Yes.
All right, thank you. So thanks. So I'll be talking about tricuspid regurgitation, evaluation and management of tricuspid valve regurgitation. This is the outline of the talk: classification of tricuspid valve regurgitation, how we grade severity of tricuspid valve regurgitation, and then indications for tricuspid valve intervention. So when you look at patients with tricuspid valve regurgitation, the etiology of it is divided into primary TR, or tricuspid valve regurgitation, and secondary tricuspid valve regurgitation. The majority of the patients with TR have secondary TR, and primary TR constitutes about 5 to 10% of those patients with TR.
Sorry, Vuy.
Primary TR. Yep.
Vuy, can you put a full screen so that we can see it better?
Yeah, I think it's on full screen, but I will let's see.
There.
Yes.
Thank you.
What about this way? Yeah,
Great.
I think it was on the wrong slide. So primary tricuspid valve regurgitation basically means the problem is with the valve leaflets or the cords themselves. And then secondary tricuspid valve regurgitation basically means the problem is not necessarily the valve itself, but it's because of other reasons like left-sided heart disease or atrial fibrillation or atriopathy that lead to dilatation of the right-sided chambers and then stretching of the valve, and you end up with secondary or functional tricuspid valve regurgitation. And as you can see from this slide, the majority of the patients are those with secondary tricuspid valve regurgitation. So this is an example of primary mitral valve regurgitation, which again is a minority of patients with severe TR. This is an example of a patient that had a flail septal leaflet from a previous biopsy. This is a patient, a post-heart transplant patient, and had a complication of myocardial biopsy. But this, you can see this flail with patients with prolapse and a ruptured cord, or patients with endocarditis sometimes will end up with the flail leaflet. But this is an example of primary tricuspid valve regurgitation. And this is an example of somebody with chronic atrial fibrillation that has secondary or functional tricuspid valve regurgitation. Nothing wrong necessarily with the leaflets themselves, but the problem and the mechanism in the functional or secondary tricuspid valve regurgitation is right ventricular dilatation or remodeling, or atrial dilatation and remodeling, displacement of the papillary muscles and dilatation of the annulus. Basically, those mechanisms pull the valve apart, and the valve ends up not being able to meet and coapt properly. And these patients can have variable degrees of tricuspid valve regurgitation. And this is just an example of one with severe TR from a functional or secondary mechanism. And you can see here pericardial effusion reflecting very high right atrial pressures and right-sided pressures from volume overload and subsequent pressure overload. You don't necessarily need to have all the mechanisms at play at once to have significant secondary tricuspid valve regurgitation. So this is a patient who has sort of this excess annular dilatation without notable tenting of the mitral valve apparatus. But some of these patients, for some reason, have annular dilatation as the primary sort of mechanism of leading to tricuspid valve regurgitation. So not a lot of tenting, but a stretched annulus, and this can be associated with, again, varying degrees of tricuspid valve regurgitation, and not uncommonly severe TR. This is the grading scheme of TR, and how do you diagnose severe TR? Obviously, if you see a lot of color in the right atrium during systole, that is consistent with a significant tricuspid valve regurgitation. But we always try to quantitate the severity using our proximal isovelocity surface area, or PISA method. So effective regurgitant orifice 0.4 square centimeter, or regurgitant volume of more than 45 milliliters, consistent with severe tricuspid valve regurgitation. Other things like a triangular shaped continuous wave Doppler signal, or hepatic vein flow reversals in the hepatic vein, systolic flow reversals, or if you see dilatation of the right-sided chambers and IVC dilatation, or abnormal tricuspid valve anatomy like a flail or a markedly dilated annulus with valves not meeting, then those are clues that the patient may have significant tricuspid valve regurgitation. Now, we know from many studies that having tricuspid valve regurgitation is not good, and a lot of work has gone into this, and subsequent studies to this one in 2004 by Nath that showed that severe TR is an independent predictor of bad outcomes. Many other studies since then have shown that severe TR is an independent prognostic factor, independent of pulmonary hypertension or RV dysfunction or anything else that the patient may have. So we know that tricuspid valve regurgitation leads to poor outcomes. Of course, the TR is a volume overload lesion. This leads to dilatation of the right ventricle and a volume as well as pressure overload, increased pericardial constraints, and then that can impact also the left ventricle. It's interesting because we always think things on the left side of the heart affect what happens on the right side, but things on the right side of the heart can also affect what happens on the left. So there's only so much real estate, and the left ventricle can get compressed. You get a D-shaped septum, decreased LV cavity size, and then not only do you have a decreased RV output because of RV dysfunction, but you can also get decreased LV output because of abnormal filling of the left ventricle. Indications for isolated tricuspid valve regurgitation: we do not have any class 1 indications for tricuspid valve regurgitation, but the guidelines do say in patients with severe primary tricuspid valve regurgitation, isolated tricuspid valve surgery is a class 2 indication and can be beneficial to reduce symptoms and recurrent hospitalizations. In patients with isolated severe secondary TR attributable to annular dilatation, surgery is a class 2B indication. But the guidelines really stress that you should exhaust all your medical therapy. So it's in those patients with severe secondary TR who are poorly responsive to medical therapy where isolated tricuspid valve surgery can be beneficial. Again, this is beneficial to reduce symptoms and recurrent heart failure. We don't have a lot of data to show that intervening on isolated tricuspid valve regurgitation has a survival benefit, but it does improve the patient's symptoms and it keeps them out of the hospital. The incidence and trends in how much the volume of tricuspid valve regurgitation has increased and continues to increase. This is older data now, up to 2013, from 2004 to 2013, showing increased utilization of tricuspid valve repair as well as tricuspid valve replacement in patients with severe isolated tricuspid valve regurgitation. But what's interesting about this, that even though we're doing more and more surgeries over time, the operative mortality is still high in hospital mortality following tricuspid surgery, about 8.8 to 10%. And this is likely related to late referral of patients with severe tricuspid valve regurgitation, where they have advanced RV dysfunction, liver congestion, renal dysfunction, because we're still trying to exhaust all our medical therapies before referring patients for tricuspid valve intervention. And then, of course, patients have other comorbidities. As I showed in the first slide, most of the patients with tricuspid valve regurgitation have a secondary tricuspid valve regurgitation with other comorbidities. So this is why the operative mortality remains pretty high. You heard about percutaneous interventions for valves, aortic valve, mitral valve, and this is happening in the tricuspid valve space as well. This is just one of the ways of doing tricuspid valve repair percutaneously, this edge-to-edge technique, both with the mitral clip and an Edwards Pascal. And as has been emphasized in the previous talk, imaging is very important to determine mechanism and feasibility of percutaneous repair. And in addition to edge-to-edge repair, there are other things that we're doing now for the tricuspid valve, including annuloplasty or percutaneous tricuspid valve implantation. So this is one of the trials of edge-to-edge repair that randomized people to edge-to-edge repair versus continued medical therapy. And of course, there was a marked reduction in the severity of the tricuspid valve regurgitation in patients that underwent edge-to-edge repair and improvements in symptoms. And again, the study showed that TIA was safe for patients with severe TR. It reduced the severity of TR and was associated with an improvement in quality of life, but the study did not show any survival benefit to doing the edge-to-edge repair. And I think, part of that has to do with these comorbidities and the fact that we're intervening late on these patients. And we looked at this issue of comorbidities here at Mayo and took patients with varying degrees of tricuspid valve regurgitation and put together sort of this trio score or this tricuspid regurgitation in outcomes score, looking at, your common clinical variables like age, sex, and renal function, whether you have a history of heart failure, lung disease, and what your liver function is all about. And the more comorbidities you have, or the higher your trio score, the higher your mortality. And the less comorbidities you have, the lower your mortality over time. And we divided this up into sort of low risk trio score, intermediate risk trio score, and high risk trio score, and then looked at the impact of tricuspid regurgitation based on the patient's trio score. So what's important here is when we looked at patients with low trio score, the mortality was impacted by severity of tricuspid valve regurgitation. So basically, the more TR you have, the higher the mortality, and the less TR you had in a patient with low trio score, the lower your mortality. So there was an impact of TR in survival in the patients with a low trio score. We saw this in the intermediate trio score, although that association was slightly weaker. And then in patients with a high trio score, whether you had moderate TR or moderate severe TR or severe TR, it really didn't make a difference on your mortality. So our thinking is that the patients that you're more likely to impact by reducing the severity of TR are those patients with a low trio score or those patients with an intermediate trio score. And so, it's all about sort of intervening early and making sure that the patient doesn't have too many comorbidities to affect their survival over time. So in summary, there's recognition that TR is an independent predictor of survival, independent of your comorbidities, depending on which patient population you're looking at. It's important to determine the etiology and mechanism and severity because that determines how you treat the patients. TR surgery typically, even today, is performed probably too late in these patients, which is why you have the high operative mortality, and we have a hard time showing a survival benefit to fixing the valve. We have this clinical TRIO score, which may predict survival benefit from TR intervention, and this is something that we're actively looking at. And then transcatheter therapies are a good alternative to surgery, obviously, in some of these patients. And with that, I will close, and thank you.
Gracias, doctor Knomo. Lo invitamos a que esté ahí en la pantalla, así puede tener unos minutos de discusión con nosotros. No sé, Martín, si tenés alguna...
No, si hay alguien del público que quiera tener, o si tiene alguna pregunta, algo que pueda compartir. Si no, bueno, tenemos que hacer un panel de discusión rememorando las charlas. Hay una charla la de valvulopatías combinadas que hablaste, Fer, y se la pregunto al panel y me pueden contestar. Hay una combinación de las valvulopatías que es la estenosis aórtica con la estenosis mitral. Hay, como la estenosis mitral ahora es una etiología degenerativa y trabajos que demuestran que se puede dejar la estenosis mitral, pero yo no sé si le exigimos lo mismo a la hemodinamia que a la cirugía, porque la cirugía podría, a través de una válvula Stenless, un procedimiento más pequeño, dejar una estenosis mitral y esperar que tenga la misma sobrevida. Mi pregunta es, al panel, a quien quiera responder, ¿ustedes se sienten cómodos? Nosotros nos sentimos cómodos poniendo una TAVI y dejando una estenosis mitral significativa, porque la podemos tratar. ¿Nos sentimos cómodos derivando a un paciente a cirugía dejando lo mismo? No sé qué opinas, Daniel.
Va a depender un poco de la edad, ¿no? No es lo mismo 80 años, 83 años, que tenés un problema predominantemente de estenosis aórtica y tiene la mitral con MAC o esas cosas que complican el procedimiento y pueden poner en riesgo la vida del paciente, que gente más joven, donde estás obligado a no ignorar la patología mitral. Así que yo diría, en cuanto a morbilidad, si tiene más de 80 años, priorizar cuál es el síntoma más importante, y el MAC es un tema, lo hemos manejado, sabemos cómo manejarlo, pero no está exenta de riesgo. Pero yo creo que la edad es el factor que te marca la conducta agresiva o no en base a la solución. Para nosotros en cirugía, cuando entramos a quirófano, es un procedimiento de mucha envergadura para el paciente. Entonces, es como tirar toda la carne al asador, digamos, lo debes hacer en la medida que el paciente tenga una edad, que tenga una expectativa de vida razonable. La paciente de 80 años, te pones a hacer doble válvula, sacar el MAC es más riesgo que beneficio, ¿no? Entonces eso es un tema.
Sí. Fernando.
Perdón, el 5. Creo que una cosa importante es ver cómo es la anatomía de esa válvula mitral, porque por ejemplo si es una válvula mitral con una valva anterior muy grande, pensar que después vamos a poder hacerle un tratamiento percutáneo sin obstruir el tracto de salida, o sea, hay que pensar un poco más allá. Si después poner una valva mitral va a generar una obstrucción, digamos, eso te va a llevar en un paciente más joven a tratar de resolverlo directamente en la primera cirugía. Y en los pacientes en los que uno va a ofrecerle plástica, lo mismo, o sea, los resultados de Valvin MAC y Valvin Ring no son tan alentadores como para decir, le hago una plástica total, después podemos venir y poner una válvula. Creo que por ahora estamos en deuda en ese sentido.
Marcelo, tiene el micrófono, ¿no?
Sí, yo le quería hacer una pregunta al doctor Knomo acerca del tema que creo que nos estamos discutiendo más, porque hablamos de la válvula aórtica, la reparación de la válvula aórtica, las biológicas aórticas, la tricúspide, la válvula olvidada. Y el MAC específicamente para nosotros es un problemón, porque la cirugía muchas veces no lo puede resolver, y cuando nos planteamos una técnica percutánea de Valvin MAC, resulta que son pacientes con mucha comorbilidad y muchos problemas, entonces muchas veces nos echamos atrás, no tanto por el procedimiento, sino por el paciente. ¿Cómo encaran ustedes el tema del Valvin MAC en la Clínica Mayo?
Yeah, no, thanks. That's an important question and an important observation. We need a new field of valvular heart disease prevention, so we don't have to talk about these things in these elderly patients. But I agree. I mean, MAC is associated with a lot of comorbidities, and one of the things that we commonly do here is to really make sure that the mitral annular calcification and the degeneration of the mitral valve is causing significant mitral valve stenosis. Because sometimes by an echocardiogram, you can see increased gradient, but that gradient is really not reflecting valvular stenosis, but reflects, stiff left atria, severe diastolic dysfunction, and all these different things. So if a person can somehow tease that out with left and right heart catheterization, we've spared some patients from going to percutaneous intervention or even trying to intervene on the MAC with surgery by determining, why the gradient is elevated and what other comorbidities they have. Because some of these patients, when you intervene, there's no change in your transmitral gradient and no change in your mean left atrial pressure, which means the problem wasn't necessarily the valve. But I agree, it's really difficult. It complicates surgical intervention because the surgeons don't want to run into problems with disconnecting things from the annulus, and it's hard to sew anything onto a calcified annulus. And then the percutaneous techniques, in addition to being technically difficult, as you show in that slide, the outcomes in these patients with MAC are really not that good. But this is not to say that we don't do it, because in some patients there is improvement in symptoms, and you keep them out of the hospital. But you really have to do an in-depth evaluation just to make sure that fixing the valve will help you.
Bueno, gracias. Voy a hacer una preguntita más al doctor Knomo y estamos, porque me parece que tenemos que terminar, pero acá el doctor Piccinini me preguntaba qué tipo de intervención hacen en los pacientes que tienen anillo dilatado tricúspide y no tienen una insuficiencia significativa, tanto si van a cirugía como si van a tratamiento percutáneo, en el sentido de decir, ¿es bueno tratar la insuficiencia tricúspide por más que no sea severa cuando ya tienen dilatado el anillo? ¿Qué pensás sobre eso en el futuro, digamos?
Yeah, no, that's a great question. So I think Dr. Cristinello, the cardiovascular surgery team here is looking into that particular question of whether you should manage the TR, whether you should repair it in someone that has less than severe TR, or at least less than moderate TR, let's say, but they have a dilated annulus at the time of left-sided surgery. I mean, this was the recommendation in the guidelines that we need to do this because those patients, after fixing the left-sided issues, tended to come back with significant tricuspid valve regurgitation. But I think we're seeing a signal that may not be the case. So if the patient has less than moderate TR, but a dilated annulus, then it might be safe to just leave it alone and not fix it just because it's dilated at the time of left-sided surgery. But I agree. I mean, this is sort of a difficult thing because some of our surgeons will still want to know what the annulus size is and then do an annuloplasty typically and not replace the valve, but they repair it by an annuloplasty band if it's dilated and the patient doesn't have significant TR. So for percutaneous interventions, I mean, we are not targeting patients with less than severe TR for percutaneous therapies. So you have to have severe tricuspid valve regurgitation. The trials that we're participating in, it's the edge-to-edge repair, but I know there's an annuloplasty band one that's being looked at. We're not a site for that, but that would probably be the way to repair the patients with dilated annuli.
Buenísimo. Sí, Ricardo, la última.
Intentaría preguntarle a Vuyisile algo que a mí me tiene muy inquieto. Las guías son demasiado tardías en la indicación de cirugía aislada de la secundaria y habla de insuficiencia cardíaca con fallo del tratamiento diurético. Nosotros tenemos claro que los cirujanos fracasan porque los mandamos a los pacientes muy tarde, Vuyisile lo mandó muy bien, y además, si no le damos a los cirujanos eso hasta que tengamos lo percutáneo bien desarrollado, ¿cómo vamos a esperar que tengan buenos resultados? Entonces mi pregunta a Vuyisile es, ¿no te parece que deberíamos desobedecer a las guías y enviar a los pacientes a cirugía cuando hay una cirugía aislada de una tricúspide con insuficiencia severa antes de que haya síntomas clínicos de insuficiencia cardíaca congestiva?
No, I mean, I agree 100% because I think on some levels the guidelines sort of reflect where we've been because it's all, they try to be data driven. So if there's no data, they're not going to support some aspects of clinical practice. But again, the data is generated from exactly what you're saying. I mean, if you think something is not making any sense, then we should try to do something different and show that there is benefit to intervening early on the tricuspid valve. And I think this is where the science is going to show that early intervention on the tricuspid valve is beneficial. But I think the problem with tricuspid regurgitation is that patients can tolerate the TR for a very long time. So we have patients that we've been following for 10, 15 years with severe tricuspid valve regurgitation before you intervene because they're doing okay. But then by the time you try to intervene, things are maybe too late. The RV is failing and the patient is more advanced. But it's not sort of an easy proposition also for the patient when they're doing well to say, hey, let's do open heart surgery and try to fix your valve when you can manage the patient with escalating doses of diuretics. But I think we do miss that window because we wait too long. So I would favor earlier tricuspid valve intervention and then choosing those patients with sort of a low TRIO score and intermediate TRIO score. So we can show survival benefit to intervening.
Buenísimo. Buenísimo. Muchísimas gracias, doctor Knomo. Gracias por levantarte temprano para estar con nosotros. Gracias a todos por participar en esta sesión. Gracias a todos los panelistas y todos los que dieron charlas. Y los invitamos a quedarse para la próxima plenaria de Cardiopatía Estructural. Muchas gracias.